All right. Hello, and thank you for joining us, everyone that registered. My name is Ruthie Marker. I'm the Education Program Manager at the Allergy and Asthma Network. I'm delighted to welcome you to this afternoon's CME accredited webinar. We have an excellent program planned and focusing on managing atopic conditions. Just a few housekeeping before we get started. Everyone will remain on mute for the remainder of the webinar just to minimize distractions. We will record today's session and it will be uploaded to our website within a day or two. You'll be able to access this recording as well as all previous webinars recorded on allergyasthmanetwork.org. Our webinar is scheduled for an hour. This will account for time for the presentation and also question and answer after the presentation. Please feel free to submit your questions at any time throughout the presentation through our Q&A box located at the bottom of your screen. One of our team members will be monitoring that question and answer box as well as the chat to see if you have any questions or have any technical issues that we might be able to answer throughout the presentation. This Advances webinar is brought to you in collaboration with the American College of Allergy, Asthma, and Immunology. The college offers continuing education credits for physicians and attendance credits for all others. You can create a free ACAI account and earn CME or attendance credits through their portal. All attendees will receive a certificate of attendance. Zoom will email you in about a day with that link, as well as supplemental resources that go along with today's material. Today's presentation is titled Managing Atopic Conditions, Prevention and Treatment of Food Allergy in Infants. Food allergy is now nearly 8% of children in the United States, with an incidence continuing to rise and increase the risk of comorbid atopic conditions such as asthma and allergic rhinitis. Understanding the effect of prevention and strategies is essential for optimizing patient care. It is my pleasure to introduce today's presenter, Dr. Edwin Kim. In today's session, Dr. Edwin Kim will emphasize evidence, information, strategies that can be applied across diverse clinical settings to improve outcomes for infants at risk for affected by food allergies. Dr. Edwin Kim is an associate professor of pediatrics and chief of the Division of Pediatric Allergy and Immunology at the University of North Carolina School of Medicine. He also leads the UNC Food Allergy Initiative, a research program dedicated to developing innovative therapies for food allergy and advancing and understanding the mechanisms that drive development. With that, I will hand it over to you, Dr. Kim, for your presentation. Dr. Kim, I think you're still on mute.
Yes, I am on mute. So
No
thank you
worries.
very much, Ruthie, for that, as well as after all these years, you figure I would be better at this, so I apologize. But again, very, very happy to be here and be able to talk on this topic, which is super important to me personally as well as professionally. I do have some disclosures here. So I do consult for several companies that are involved in the food allergy space, in particular around developing therapeutics as well as preventive type measures as well. All right, so our learning objectives. So first, we'll try to, again, explain the evidence supporting early food introduction as an effective strategy for preventing food allergy. And the fact that we can say that word preventing is just exciting to even hear it. Number two, to differentiate among current and emerging treatment options for food allergies. So we'll touch briefly on oral, sublingual, epicutaneous, as well as biologic therapies. And then finally, to incorporate shared decision making to guide the individualized prevention and treatment plans. And so it'll only be a couple slides, but probably the most important slides of the presentation. And so just to start out, I mean, like I kind of hinted at, it's so exciting to be in food allergy right now versus when I first came out of training 12 years ago, because really now the approach to food allergy is transforming. And so, what do I mean by that? So first of all, one of the things that I want to make a point of that I think all of us on this call probably recognize is delaying introduction of allergens. It just hasn't worked. So historically, many of you on the call may remember, but there was sort of this mantra of wait till age 1 for milk, age 2 for egg, and age 3 for peanut allergy, with the hope that the kids' immune systems would mature and they would be more conversive. And so perhaps that is a way that we can protect our kids and prevent food allergy. Unfortunately, though, you see the infographic on the left from FAIR that it hasn't worked. And so unfortunately now it's common to refer to food allergy as actually an epidemic at this point, with 32 million Americans potentially having food allergy. And importantly, with kids, the concept of 1 in 13 children, and another way to think about it is 2 kids in every US classroom potentially having a food allergy is just, it's bonkers to even think about that. And um, yeah, and so, again, food allergy, delaying introduction has not helped. How about once they actually become allergic? Also, what we have found is that when they're allergic, historically, what we used to tell them is, okay, here are instructions on how to avoid the food. Here's your epinephrine auto-injector, and, we'll keep you safe in that way. But unfortunately, what we also have learned now is, or not maybe learn now, but just say more out loud now, is that avoidance also is not good enough when you're allergic. And so we've got the two laws here, the Food Allergy Labeling Consumer Protection Act, as well as the FASTER Act. These two laws in the US require the labeling of the top 9 allergens. So our milk, egg, wheat, soy, peanuts, tree nuts, fish, shellfish, and then of course number 9, sesame. And so that by itself would seem to be something that should be helpful, since again, it's going to call out specifically the most important allergens or the most likely allergens. Unfortunately, though, what everyone also recognizes is simultaneous with that has been the advent of what we have recently now been calling PAL, precautionary allergen labels. And unfortunately, these are the ones that are much more commonly seen. They're voluntary, and then importantly, they're not regulated in any way. In the US, there's an estimate that 17% of all products in a supermarket have some form of precautionary allergy label. And you see an example of that in the bottom left corner, where you see the clear-cut sort of US law contains wheat, soy, egg, and milk. Again, no wishy-washiness, very clear. But then you have the may contain traces of tree nuts. So what does that mean? Are they in there? Are they not? And so that's the problem that families with food allergy have run into, is trying to read through the labels and actually understand what it means. And so the consequence is that food is still one of the most common causes of anaphylaxis that's seen in emergency rooms across the US. Um, but perhaps maybe most important, and again, I'm very um, I guess I don't want to say excited, but I think it's very important that this last bullet has actually come to light more recently. And so avoidance by itself is not benign. And so I think that's something that we hadn't really talked out loud about in the past. But avoidance, we know it leads to fear. It leads to social isolation. There's a restriction of daily activities that the patient and the families have. And then all of this sort of ultimately leads to this poor quality of life. So even if you're only having maybe an allergic reaction once every couple of years, every day these are kids, these are families that are living in fear. They're scared about where they're going to go to eat or what activities are safe. And even the process of having to think through that creates sort of a level of burden and stress that can really wear on a family. And so I think it's really important that we are talking out loud about this and thinking how treatments can not only protect against allergic reactions, but potentially help against this as well. But the great news is, why I'm saying that things are changing is that we don't have to just wait for food allergy to happen anymore. So it's not sort of this idea of passive, just wait for some, like, oh my goodness, we're going to avoid and just hope nothing bad happens, but we can actually do something. And so first I'll talk about a paper that hopefully everyone is very familiar with. So this is the Learning Early About Peanut Allergy study, published in 2015, the LEAP study. As a reminder, what this study looked at was 4 to 11-month-old children that were at high risk for peanut allergy. And what does high risk mean? These are kids that had significant eczema or already were diagnosed with egg allergy. And the idea of this study was, okay, rather than wait for food allergy, which is what we talked about is not working, the idea here was, what if we get them the food super early before they have a chance to become allergic? Can we prevent the allergy? And so the idea was ingesting at least 2 grams of peanut 3 or more times per week, starting at 4 to 11 months of age, and then following it through all the way to age 5 years. And so what we have seen way back in 2015 was that this dramatically decreases the rates of peanut allergy. And so what you see is, I'll focus on the right side of the screen, which just looks at all the patients combined. And in the group of kids where they didn't introduce peanut, they continued to avoid it. 17% of this high risk group ultimately became allergic to peanut by the time they're age 5, compared to the ones that actually intentionally started to eat the food early, eat the peanut at 4 to 11 months of age, where only 3.2% of those patients ultimately became allergic. And so did it completely remove peanut allergy? No, no, but it's clear from the bar graph that much, much, much less kids became allergic once they were able to introduce that food, again, early before they had a chance to become allergic. Now, a slide that maybe you all have not seen, though, is they've continued to follow these kids. So again, this was super exciting in 2015. By the time they reach age 5, this does seem to prevent it. But first of all, there was a question of, well, once you sort of let go of that eating it regularly, do they then flip to become allergic? And so the middle part of this screen is the leap-on study. So what they did here was then they actually took the peanut away from all these kids for a year and then have them come back and challenge again to see all these kids where it looked like the peanut allergy was prevented, did they suddenly flip and become allergic? And what you see is on the left was that age 5 leap data, and then in the middle, 1 year off of peanut, and the bar graphs look essentially the same. So if I recall, there might have been 1 or 2 patients in each group that suddenly became allergic in that year, but it wasn't that this huge number, and the bars didn't become even, and all those kids that were prevented didn't suddenly become allergic, which was very, very, very encouraging that what we were doing was actually making a lasting difference. Now, on the far right is what's called the LEAP trio study. So what they did here was then, after that 1 year off of therapy, they reintroduced peanut, and the idea was, well, eat it when you want. So kind of like if you weren't allergic, you eat it as much as you want when you want, and then let's see what happens when you're age 13. And so again, the great news here is that the percentage of patients who are not allergic, that green bar, none of those patients, or very few of those patients, or no new patients became allergic. So 4.4% were allergic in this group as well. And so all the way out to age 12, 13 suggests that this early intervention that we did lasts all the way out into adolescence. And so again, just further evidence that this is so, so, so important that we get in there, in particular with the kids that might be at higher risk, but really across all kids, and really get that message out there that we can do something about food allergy, about peanut allergy, and try to prevent that. Now, what about the other foods? And so, of course, peanut, we've got a lot of data, and a lot of groups are starting to or have been trying to introduce peanut. But what about the other foods? And so there was a study that was run in parallel called the EAT study. So this looked at 3-month-old patients that were exclusively breastfed. And then they tried to look at broadly across multiple foods. So early introduction, not just peanut, but milk, peanut, egg, sesame, fish, wheat, and then follow these kids out to age 3. So already just by even this description, you can tell that this is a much, much harder study than just doing peanut. But really important that we try to do this to get a sense of, is there something special or magical about peanut, or is this same concept of prevention possible for all the other foods that people could become allergic to? This is some of the data from the EAT study. And so like the headline, what I have at the top is really, I think, kind of boiled down. So the effect was not as dramatic, but it does look like the early introduction of the other foods was also beneficial as well. One of the reasons that it was probably not as dramatic was, like I hinted at, the protocol was much harder. So we're trying to program in the early introduction of all these foods and then making sure that those foods are in the diet. And that's a lot of different foods that were there. And so only 42.8% of the patients were actually able to do kind of what the protocol had asked for in this early introduction cohort. And so again, hard to really make dramatic sort of conclusions from data when less than half of your patients can actually do what we're asking them to do. But even with that sort of 42.8% adherence, when you got to age 3, we still did see a decrease in allergy, and it specifically stood out when we looked at egg allergy and peanut allergy. So again, immunologically, there's not a reason to think that the other foods would be very different from peanut as far as prevention is concerned. And then there's some supporting evidence here. Again, not perfect, but some evidence here that, yeah, we can prevent not just peanut, but egg and likely the other foods by early introduction. So what should we do? So I think the key point that I try to make with my families is going to be, at this point, there is really no benefit to delaying introduction. So there's no, the idea of like, I'm going to wait till my kid's 3 or 4 or 5, that is not going to potentially, that's not going to increase the chances that it's going to prevent the allergy. Now, again, culturally, that might make sense, and that's a different story. But from an immunological and a preventing food allergy point of view, there's no benefit to delaying the introduction. We do think that the skin is the portal that allows for these kids to become allergic. So the ones that avoid it, we do think that the skin is the likely reason they get exposed to the food, likely through the skin, that allows them to become sensitized and allergic. So skin care and management of atopic dermatitis is critically important in early infancy. So whether that's going to be moisturizers, whether that's going to be topical steroids, whatever works with your allergist and your primary care, but we do think that that will be very, very important. And then what we've just been talking about, early introduction of these allergenic foods. Again, the data is very clear for peanut and promising for the other foods that we can try to prevent the onset of allergy to peanut, egg, and other foods. All right. So what if we feed them early and we still saw that 3% or so? What if some of them still become allergic? Then what? And so again, the nice thing is now we don't have to just sit back and wait. We don't have to wait for something bad to happen, but there are actually approved treatment options that are now available. And so you see press releases for two of the options that are available to us in the clinic at this point, and we'll talk a little bit about each of these. So first, let's talk about oral immunotherapy. And so many of you may be familiar with what this is, but just to make sure we're all talking about the same thing, a term I've started to use a lot more of is the idea of exposure therapy. Some of my patients like to use that term, and I think it just makes it easier to understand. So really the concept of the oral immunotherapy, or really any immunotherapy, is going to be gradually increasing ingestion of the food to increase that person's threshold. So how much food it takes to trigger a reaction. It tries to increase that and thereby prevent allergic reactions if you get exposed to the food. Typically, when we do it, it involves a multi-month buildup process. Again, starting with small amounts of food and then increasing that. And then it's followed with a regular, likely daily ingestion of the actual food itself as what we call our maintenance dose. There is an FDA-approved formulation for peanut that you saw the headline a second ago, but supermarket foods are also increasingly used off-label to treat for the other foods with oral immunotherapy as well. At the bottom of the screen, you see an example of what a protocol might look like. So you see these multiple stepwise buildups, starting from very low doses up to what they determined for the peanut FDA-approved peanut product, the maintenance dose of 300 milligrams, and then that dose is continued daily for however long that patient is going to be treated. The great news is that study after study after study has shown that OIT can work. OIT can desensitize, it can increase that threshold that it takes to trigger allergic reaction and then provide that level of protection. On the left, you see the first double-blind study of peanut oral immunotherapy that was published way back in 2011. And in the right side, you see the phase 3 study that led to the FDA approval of the peanut product published in 2018. And so over and over again, we've seen that peanut oral immunotherapy can work. But here, the point of this particular talk is looking at those young kids. So, okay, we tried to prevent, it didn't work. Can we treat in these young toddlers shortly after diagnosis? Is OIT feasible? And so a study that I'd like to talk about is called the IMPACT study. So this was sponsored by the Immune Tolerance Network, which is funded by the National Institutes of Health. And this specifically looked at oral immunotherapy, peanut oral immunotherapy in 1 to 4-year-olds. It says 1 to 3 to kind of be inclusive, but up to the age of 4. And so what this study found was, yeah, it works. So OIT provides super strong desensitization. And so what you see here, and let's focus on the bottom part of the figure here, per protocol. What that means is just looking at the patients that were able to actually complete out the entire treatment. And what you find here is for the kids that were actually getting the peanut oral immunotherapy, 84% of these kids were actually able to eat a full serving size, 5 whole grams of peanuts, so 16 to 20 peanuts at the end of the 2.5-year treatment period versus only 3% of those kids that were getting placebo. And placebo, we're talking about a 2.5-year treatment period in toddlers. So really what that's trying to identify for us is how many of these kids are actually naturally outgrowing it. And so clearly very, very few versus 84% of these kids on the peanut oral immunotherapy were able to get this super high, essentially full serving size threshold. Above that, what the intent to treat is measuring is what that is counting is anyone who wasn't able to finish the treatment, whether they got tired of it, whether they had side effects, all of those kids were considered to have failed. And so if you think of it in that way, 71% of everyone that came into the study that got peanut oil immunotherapy was able to get to this full serving size 5-gram desensitization versus only 2%. What was also super important, though, with this particular study was really the idea that, okay, these young kids, their immune systems are still developing. And so perhaps we can get a longer lasting kind of benefit. A tolerance is really what we're hoping for, or in the case of this paper, we called it remission. And so for the first time, we actually found that in this case, after 2.5 years of treatment, if we took the treatment away, if we took the peanut exposure away for 6 months, what happens? Do they flip back and become immediately allergic? And what we found is some do, but 21% of these kids 6 months later, we're still able to eat that entire 5 grams of peanut without any symptoms at all. Versus again, the likely one kid who outgrew peanut alone on his own in the placebo group. And so the glass half full side is that OIT can have this potential for a very long lasting benefit. The glass half empty would be, well, a lot of these kids did become reactive during that 6 month period off. But what's not shown in this data is those ones that became reactive, pretty much every single one of them ate nearly the entire 5 grams, but just had some symptoms at the very, very end, suggesting that they did lose some, but they didn't flip back to becoming just as allergic as they were pre-treatment. So it does look like there is some level of lasting, maybe not permanent, but lasting benefit that comes. Now we've talked a little about age, and so this figure on the right from the same paper tried to look at can we predict who are the kids more likely to get this lasting benefit? And long story short, what they found was one important factor is how old you are when you start the oral immunotherapy. And what they found were the 1 to 2 year olds had the highest chance of getting the 6 month remission versus the 2 to 3 year olds who had a little bit less, and the 3 to 4 year olds that had less than that. Does that mean we can't treat a 3 year old or a 4 year old or a 7 or a 12? No, absolutely not. We've got, again, many studies that have shown that OIT can work in those groups. But it does seem that if you can get in there super early, when the kids are shortly after being diagnosed, age 1, maybe age 2, that potentially you can have an even more lasting benefit. Thinking about age, biomarkers also sort of support this concept of starting OIT young. And so there is sort of this window of opportunity. We know that a lot of the kids, when they first become diagnosed with peanut allergy, their IgEs may start at a low level. And then over a period of 3, 4, 5 years, that IgE level will sort of increase. And so what we find here is on this figure, if we look on the far left, this is graphing out peanut IgE. And so I'll have you focus on the dark blue, red, and green lines. And what those are representing is dark blue are the kids who ultimately got the 6 month remission. The red ones are the ones that were able to get the full serving size on the treatment, but then had some symptoms after 6 months off. And the green ones are the ones that had some benefit, but never got to the full serving size. And what you see there is those lines separate out pretty nicely where the dark blue, the ones that got remission, are the ones that started with the lowest IgE. The red ones were sort of in the middle, and then the green ones had the highest IG when they had started that therapy. Um, and so it does seem to suggest that if you can catch them early before their IG has a chance to increase, then maybe you can have a longer lasting sort of benefit. Now, interestingly, is when you look at the light blue line, that supports the same concept. So that's the placebo group. And what you see for the placebo is their IG doesn't stay the same. But over the 2.5 years, 3 years on the treatment, just like I just mentioned, you see their IgE does increase sort of naturally. And so even for the kids that maybe don't get the remission, if you can get in there and prevent their IgE from skyrocketing, maybe there still is a long-term benefit even without the remission at that time point. So again, this window of opportunity concept, I think, is very, very important with these young kids. Now, again, like that's not the end all be all. Clearly, we all know that. So OIT is not perfect. And one of the big problems is it comes with a lot of risk. So it is an exposure therapy. We are actually giving these kids what they're allergic to, in this case, peanut. And so this study, the PACE study, now actually way back in 2019, demonstrated that looking at kids that are getting peanut oral immunotherapy compared to the ones just avoiding, not surprisingly, they have an increased chance of anaphylaxis. They have an increased frequency of anaphylaxis, and then an increased requirement to treat a symptom with epinephrine versus if you were just strictly avoiding it. None of that is necessarily surprising because we're giving them what they're allergic to. But at the same time, again, if you think sort of, if you put your, if you're the parent of an allergic kid or you have the allergy yourself, understanding that this treatment can just as much protect you, but also kind of could lead to the thing that you're trying to avoid, that reaction does become important. And so for some families, that's too much of a risk to overcome. Whereas other families do see, okay, if I have that potential to get, my goodness, a whole serving size level of desensitization, or even the potential for a remission, a 6 month remission, this level of risk is important to keep in mind, but it may be manageable. And so again, I think it's important for people to keep that in mind. But I think recently, in particular, once the FDA approves the oral immunotherapy and it started to become even more widespread over the last few years, I think what we've recognized is, okay, maybe the risk we can manage. But what we've also noticed is that not everyone can do OIT. The actual administration of OIT itself can be very difficult both for patients, but also for allergy offices, for providers as well. So number one, the dosing restrictions that come with OIT can make it really hard to do. So OIT should be given on a full stomach. That means that that child should have had some sort of meal shortly before that. Um, Exercise and hot showers for some patients can potentially trigger allergic reactions to what should otherwise be a safe dose. And so there's guidance that trying to avoid those two activities for a couple of hours around the time of dosing. If patients are sick, if they have fever, they potentially again can become reactive when they wouldn't otherwise. And so those factors right there alone, thinking about your own families, can you find that window of time? And if you try hard enough, yeah, a lot of families can, but it may not be easy. If you have the kid who's coming home and has some sort of sports or instruments or homework or whatever it may be, or say you have a family that where again they're living in two different households, how do you find this time? And so some families can do it, but other families may not be able to. We also know that specific to peanut, a lot of the kids just the taste, the texture, the smell, it's pretty rough. And then asking that same kid to try to eat this on purpose every single day, some kids are able to overcome this and do it, others maybe not, and that's okay. But it's important for us to recognize that. And then in particular, when we think of the youngest kids, we have quote unquote good eaters, where you give them what you want and they'll just eat it right away. But there's some kids where maybe they just don't eat as well. It takes them 30 minutes to eat their meal. And if you have to do peanut and it takes 30, 45 minutes and you have to do it every single day, just may not be feasible in the long term for that particular kid. Also, separate from the dosing, the actual visits to the office can make it quite difficult as well. So I showed you that ladder diagram. So that's what, 10, 11, 12 visits to the allergist office within the first 6 months of treatment. And so, the family circumstances, work schedules, school schedules can make it really, really tricky. And for some families, they just may not be able to go into the office to meet sort of those protocol days. Also, again, you may be lucky enough where you say you live in perhaps New York City, or even here in Chapel Hill, where I live, where we have many allergists that are around us. Great, you can find an allergist. But what if you live somewhere where the nearest allergist is a 2-hour drive away? Again, can you do a one-time visit? Maybe, but can you go every 2 weeks for 6 months or a couple times a year after that? It suddenly becomes trickier. And so not everyone might be able to benefit from OIT because they just can't actually do it. And so this is where I'll kind of segue into sublingual immunotherapy, which is something we've studied a lot here at the University of North Carolina. And it's as an alternative to be considered to OIT. And so the potential for food sublingual immunotherapy, that comes actually from a lot of experience we've had using sublingual immunotherapy for pollen allergy. And what we're talking about with sublingual is the idea that we're actually giving the actual food, or in the case of pollen, the actual allergen underneath the tongue in a liquid form that's diluted in this sticky glycerin preservative. The thought is that the sublingual actually accesses the immune system, specifically what we call these oral Langerhans cells underneath the tongue. And then those will take up the allergen and then promote the tolerance that we're looking for. So back to the kids. Okay, so maybe we're doing sublingual for pollen allergy for adults. Okay, but how about for little kids, for toddlers? Can we do it? Does it actually work? And so we were able to do a study that was jointly funded by the National Institutes of Health as well as FAIR. And this was the peanut immunotherapy sublingual trial. And so we designed a study based off of two successful studies of peanut slit in elementary school age children ages approximately 6 to 7 years old. And in this particular case, we included 50 peanut allergic children ages 1 to 4 years old. And then we treated them with just 4 milligrams of peanut in the form of slit compared to placebo for 36 months. The 4 milligrams is important just as a reference. One peanut kernel is approximately 300 milligrams, and that's the dose that of the FDA approved oral immunotherapy product. So 4 milligrams, of course, is just far, far, far less. And we think that's where the safety comes from. But again, does it work? One of the nice things with sublingual is across all three of our studies, we've not had the exercise restrictions, the shower rules, mealtime restrictions with this compared to the oral. And then for this particular protocol, we were able to shrink the time in the clinic down to just 5 monthly visits and instead included some updosing that patients could do in their own home and not have to come into the office. Hopefully finding sort of that happy medium of observed doses and education with the allergist. But again, not having to come into the office nearly as much to make it more feasible. And so what we found was, yeah, with these young toddlers, they can do really well. So they got high thresholds and with this. And so first of all, those 50 kids, the median age was 2.2 years. So really, really young kids in this study. And what we found were, again, similar to what we talked about with the impact study. If we count patients who weren't able to finish the treatment, if we count them all as failures, even with that, 60% of the kids on sublingual were able to eat the entire, in this case, 4.4 grams. I still would think of this as essentially a serving size for a young kid at this age. 60% were able to eat the 4.4 grams versus none of the kids on placebo after the 3 years of treatment with this peanut sublingual. If we only counted the kids that are able to complete the treatment itself, nearly 80%, 79% of the kids were able to actually eat that whole 4.4 grams of food versus, again, none on placebo. So really, really strong benefit with just a little measly 4 milligrams daily of sublingual. So an exciting outcome that we had seen. Um, and then similar to the impact study, we wanted to see, are these immune changes that come with sublingual, do they last to some extent? And we were a little bit nervous to go out as far as 6 months, but in this case, we took away the peanut treatment for 3 months to see if that benefit lasted. And for many of the patients, it actually did. And so what we found were 48% of those patients were still able to eat the 4.4 grams 3 months after stopping the sublingual and any peanut sort of exposure. If you count again, all the kids who finished the treatment, 63% of those kids were still able to eat the serving size 3 months after stopping the treatment. Do I think again this is a cure? No. Just like with the impact study, I do think that if you give it enough time, that reactivity is probably coming back. But this is a great sign to me that it's not overnight. It lasts for a while, and so even if you miss a few weeks or even a month or two, I do think that the majority of that benefit is likely still there for these patients, which is really, really reassuring for these patients. Now, how about the age concept? So we talked about impact that younger was better. So we tried to similarly look at that in this study. And first on the left side, what you see here is when we split it up into 1 to 2 year olds, 2 to 3, and 3 to 4, sure enough, it does look like starting at 1 to 2 gives you a stronger chance of getting that full serving size 4 gram desensitization. And even with the 3 month remission, not as clean as on the left side, but we still see that the 1 to 2 year olds seem to have a slightly stronger likelihood of getting that remission as well. So further evidence that not just with OIT, but even with sublingual, if we can get in there early, if we can get in there when the kids are still sort of 1 to 2 years of age, I think it may be easier to do the treatment with the potential to have a slightly longer lasting benefit for those kids as well. Now let's talk about sort of another treatment that's in development. So sublingual, again, I think could be a nice option for some families rather than OIT. And epicutaneous immunotherapy is another option that will be super exciting. Again, still in development, but the potential is very strong here. And so essentially what this is a medicine patch for peanut allergy. And so what this patch includes is 250 micrograms, so the equivalent of 1/1000th of a peanut. So really, really small exposure to peanut. And it's on a patch that's applied daily to the back. The most common side effect is, not surprising, it's going to be skin irritation because we're exposing the skin to what the patient is actually allergic to. But the concept is you put it on for 24 hours and then you rotate across 6 spots on the back to, again, try to manage and minimize any sort of irritation or itch that the patient may have. Thankfully, again, it makes sense if you're not eating large amounts of the food. Thankfully, severe reactions and reactions that are treated with epinephrine were very rare with this treatment as well. And so again, a lot of potential on the safety side, and it's very easy to see how easy this would be to actually do, to administer. Does it work? And so toddlers do seem to achieve significant desensitization when we use this peanut patch, the peanut epicutaneous immunotherapy. So this is called the Epitope study. So this was looking at 362 toddlers ages 1 to 4 years. And here you see the median age of this study was 2.5 years. Again, that same 250 microgram, 1/1000th of a peanut, applied daily for 12 months in this case. And what we see here is 67% of the ones that were getting the peanut patch met the responder criteria versus 35, oops, that's a typo, 33.5%. Oh, sorry, never mind, it is correct. So 67% of these kids were responders compared to a prior study that's not on this slide where only 35% of older kids, kids up to age 8, were responders. And so it does suggest that the younger kids do better than the slightly older kids with the peanut patch. And then thinking about the side effects, so the itching, that the irritation that may happen on the skin, um, would any of that, like, do any patients sort of discontinue treatment or not able to complete treatment? And so 8 out of 244 patients on the patch withdrew from the treatment because of those side effects. So again, there are going to be some kids where this is not the right treatment for them as well, but the potential for benefit here is very big, with really good safety and then very simple sort of use. So for the last bit of time, let's talk a little bit about biologics. So it's been sort of in the news, and if you've been to the allergist office, you've probably already had this conversation. But what about biologics for food allergy? And so, or why do we even need to have this conversation? So number one, daily treatment with anything is difficult. And so daily treatment with immunotherapy, this exposure therapy, is going to be hard to sustain for some families, if not a lot of families. The dosing restrictions, the finding time for dosing with OIT, like I mentioned before, it can be very difficult for some families. Um, but also, what we know with immunotherapy is right now, immunotherapy is food specific. So peanut immunotherapy will not treat your cashew allergy, it won't treat your egg allergy, it only treats your peanut. But unfortunately, 40 to 50% of our patients actually are allergic to multiple foods. And so when we're trying to do immunotherapy, if we're going to try to treat multiple foods, it just becomes exponentially harder, either more risky or more burdensome or more time. And so one benefit of biologics is that they potentially should be able to treat multiple foods simultaneously because they're hitting the immune system at a point before it actually you get to the specific foods. Also, biologics don't include the food itself. There's no food exposure, so there is no risk of these food reactions or food aversions that we may be talking about with OIT or even with sublingual. And then sort of the added like treatment plus, benefit plus is that some of these biologics maybe will actually treat the other allergic diseases simultaneously with the food allergy. So if you have a patient that has comorbid eczema or asthma, the biologic may have the potential to treat both food allergy as well as the allergic disease. So these are some of the sort of why are we even talking about this kind of stuff. The one that we've studied the most is going to be omalizumab. So this is an anti-IgE therapy. And so this is important because we know that allergic symptoms are caused by histamine release when IgE on the mast cells bind to the allergen. And so this tries to grab that IgE and take it out of circulation. One really nice thing with omalizumab is that this is not a new drug. And so this has actually been around for quite some time. So originally approved in 2003 for allergic asthma, 2014 for chronic urticaria, 2020 for chronic sinusitis with polyps. It is a shot though, it's an injection. So this is super important for patients, especially if we're talking about these young kids, these toddlers. It is a shot and potentially could be every 2 to 4 weeks. So that in itself may not make it right for every kid that's out there. So the main study that we'll talk about supporting omalizumab for food allergy is what's called the OUtMATCH study. So this looked at actually a huge range, patients ages 1 to 55, and patients had to be allergic to peanut, number one, and then they also had to be allergic to at least two other foods of the list of milk, egg, cashew, walnut, hazelnut, and wheat. So again, had to be allergic to 3 foods, peanut plus 2 other foods. And in particular, what I'll focus on, this is sort of the study summary, which is quite complicated, 3 whole stages with an extension. But what I'll focus on is the simple stage one. This is going to be omalizumab versus placebo. And so this is the primary outcome from the study. And so what you see here in the graph is going to be the gold bars are going to be on treatment with omalizumab, and the blue will be with placebo. And the shaded on the far left of the figure is the primary food. So peanut was the key food for everyone had to be allergic to. And sure enough, what you see is 67% of patients were able to actually eat at least 1 gram of peanut at the end of the 4 months of treatment versus 7% of those on placebo. Then when we go down the line and look at the other foods that potentially they were allergic to, cashew, egg, milk, wheat, you clearly see gold versus blue bars that there is a clear difference. The gold bars demonstrate that omalizumab can treat all those different foods significantly better than what you might get with just plain old avoidance shown with the placebo. Now, what's important though, I think, is a couple of things. Number one is going to be the thresholds for success for peanut was 1 gram versus for the other foods was 2 grams. So there was a slight difference there. And then it is noticeable that cashews seem to have a lower number, whereas all the other foods were sort of high 60s to 70%, pretty uniform. Cashews seem to be 41%. So one of those that we're trying to understand, okay, is there something unique with cashew? Is the dose wrong? Do we need to treat longer? Some of these aspects. So clearly better than placebo, but different than the other foods. So something that we are paying attention to and trying to investigate. Now, this is a figure that was also in the paper as well. And I really like to look at this papers because, or this particular figure, because here this shows actually every individual patient as opposed to sort of those bar graphs that show lumped together. And here, I do think it's pretty easy to see that pretty much all those orange lines are pointed upwards. Some higher than others, but it does seem that the vast majority of patients are getting an improvement when they're on the anti-IgE therapy. And so that's number one. Number two is when you see the black bar, these are the median levels. And what you see is the level that patients are achieving is not just a little bit better, but the median levels for these foods are very high. And so where you see is with peanut, the group started with a median threshold, so only 44 milligrams of peanut to trigger a reaction. By the end of treatment for the group as a whole, that median amount goes all the way up to 4 grams. When you look at egg, milk, the other foods, these are going up to 6 grams and 4 grams, so very large amounts for the group. Again, cashew stands out as improved for sure, but only 444 milligrams for the group. So again, something unique about cashew, perhaps, so we'll look into it. Now, there are a few patients that don't respond. You see some of these gray bars that go downwards, and there are some bars that are fairly flat. And so in the study, it looked like about 14% of patients didn't really improve with peanut. So I think that is important, that it is a good product, but it doesn't look like it's sort of a perfect product. And so an important conversation that we have with our families and our patients that most patients will do well, but there will be some that will not respond. Now, in the last couple minutes, I'll talk about one other biologic that we see a lot in the clinic. So dupilumab is an anti-IL-4 receptor alpha. And this actually blocks, one of the ways that this medicine works for allergic disease is it actually blocks IgE class switching. What that means is it blocks our cells from switching and making more IgE. It's approved all the way down to age 6 months of age, which makes it relevant for this particular conversation with the young kids. Approved for eczema down to 6 months of age. What's important is it's also not just eczema, but it's approved for asthma, for polyps, for EOE. So it is a medicine that seems to be very effective across multiple allergic diseases. It drops, it's given by an injection, a shot similar to the omalizumab, so biweekly subcutaneous injections. One nice thing it is approved for home use. And so what this figure on the right is trying to show is looking across atopic dermatitis, eczema, asthma, chronic rhinosinusitis, EOE. One thing that they found across all these studies is that on the dupilumab treatment, IgE goes down for these patients. And so if you can drive down the food IgE, hey, could it work for food allergy? And so that was something that we wanted to know. And so 2 studies were done. And unfortunately, the sort of final answer here is not very impressive. So when they looked at 24 weeks of dupilumab on its own as a monotherapy, it did decrease the Ig as we had hoped or as we had expected. Unfortunately, when we actually went to food challenge to definitively show are the patients better, only 2 of the 24 patients were actually able to eat even 1 peanut worth after treatment. And again, keep in mind when we're talking about oral immunotherapy, we're talking about serving sizes. We're talking about 4 or 5 grams. When we're even with omalizumab, we were seeing patients 1 to 4 or 5 grams. And so here, only 2 out of 24 are able to get the 300 milligrams. So again, not very impressive with this short 24-week treatment period. On the right, what they looked at was, well, what about dupilumab in conjunction with OIT? Is that like by driving down the Ig at the same time as the OIT, could that potentially make the OIT safer or better? And again, there was a small improvement. So what you see here is during the updosing, passing a food challenge, the light blue is going to be on the combo of dupilumab plus OIT versus placebo and OIT in the gray. And the blue bar is bigger, but 34 to 54%, so a little bit better. And then when you look at the maintenance phase, again, that difference becomes even smaller. So yes, there is some improvement in the food challenges, but not a dramatic one at this stage. And so again, an early sign that dupilumab may have some benefit, but again, maybe it's somewhat limited in what it can provide. And so to wrap up in the last couple minutes, what is the best approach for my infant with food allergy? And so number one, I think everyone hopefully recognizes it, but there is clearly no one size fits all for food allergy. Every situation can be different. First of all, on the side of like, how does food allergy impact that patient? Like for some kids, it may sort of affect their ability to go to this school, or it may affect their nutrition, or every kid is going to be affected differently with it. but then also sort of what does a food allergy look like? What is their IgE? How many foods are they allergic to? What other sort of comorbid stuff they have? And so I think there is going to be no one size fits all treatment for food allergy, at least at this point. Peanut oral immunotherapy there's an FDA approved version of peanut oral immunotherapy, and then omalizumab is approved by the FDA. And they're both available for patients that are ages 1 and older. And so again, for that, those patients that we try to prevent and become allergic, these are approved options covered by insurance that could be available in the clinic. Sublingual and epicutaneous immunotherapy, both of those have really good looking data for these young toddlers as well. Sublingual, there is no FDA approved formulation at the moment, and epicutaneous immunotherapy is currently in phase 3 studies, and hopefully will be something that the FDA will judge on in the near future. Each of these different treatments, OIT, sublingual, epicutaneous, omalizumab, each of these has a different degree of desensitization, a different degree of safety, as well as sort of the difficulty of actually doing the actual treatment itself. And so this is where that shared decision making is going to be really important. Really trying to get at like how does food allergy impact that particular family, that particular patient, and then which of these different treatments can kind of help them get there the best. But the key piece here in my mind is starting with how is the food allergy impacting the family? What are they looking for in a treatment? And then coming to the treatment to figure out which ones maybe sort of best help them get there. Important though is the last bullet. So we've talked a lot about treatments here. We've talked about how we don't have to be reactive, we can be proactive. Avoidance is still and will always be an option. And so, but one thing that I think is important now is I think of it as an option. This is not one of those where we're all forced into avoidance, but we can actually choose, okay, my particular kid with food allergy, omalizumab, maybe that is an option. It's maybe OIT is an option. What are the pros and cons of that? And what's the pros and cons of avoidance? And so to really be able to think of those all as options, and then maybe in my case, I'm going to say, I'm okay with avoiding now. And then maybe when my kid is about to go to kindergarten for the first time, that's when I'll come back to it because that's when I think it'll be most impactful for me. And to be able to have sort of that decision making, I think is going to be essential. And so food allergy is in a paradigm shift. Again, really exciting for this. Like I just mentioned, we used to just be reactive. We sit back and kind of wait and hope we don't become allergic. If we became allergic, we sit back and just hope nothing bad happens. We don't have an allergic reaction. Those days are gone in my mind. Now it's all about being proactive. How do we get in there and prevent it in the first place? And if we don't prevent it, okay, that's fine. How do we get in there and do something about it? How do we protect against the food allergic reactions? How do we allow our kids to sort of more normalize and just be there with the other kids just like they should be? And so prevention and treatments are possible. And there's a lot more coming. Like I mentioned, avoidance may be okay because there's more stuff that is coming. So we've been very fortunate where there's been a lot of ongoing research and products that are sort of in kind of really close in development, as well as some that may be a little more distant. But I do see a lot of innovation coming ahead and lots of reasons for hope for our kids. All right. Ruthie?
Thank you so much, Dr. Kim, for that excellent presentation. I know you provided the audience and even myself with awesome and important information about managing atopic conditions in the setting of food allergies. I see some hands up, so please feel free to submit those questions through the Q&A box. We do have some questions we'll get started with. The first one is, what is your recommendation, Dr. Kim, for families with 3 or 4 generations of anaphylactic food allergy reactions?
3 or 4 generations of food allergic reactions. So in trying to guess what the reader or the question is coming from is situations where people are allergic to different foods can definitely be problematic. And so if you may have a parent that's allergic to peanut, but then a kid that's allergic to tree nuts, and how in the world do you manage sort of those? And especially if we're talking about early introduction or treatment, that can definitely create sort of a complication of how do you introduce peanut to the young toddler, like the young infant, when the parent themselves is actually allergic to that. I don't have a great answer to that. Families have been very, very creative, whether they have sort of separated out with other family members to try to do that. Or again, just again, coming up with sort of different strategies. But this is definitely a situation I think is tricky. I think one thing that's very, very important as a reminder here is that when it comes to allergic reactions, it is really important that the majority of sort of significant, like it really will take sort of ingestion to have larger allergic reactions as well. Um, and so I think any ways that you can sort of be very, very careful if the other person is allergic to watch what is being sort of on your hands, what is being eaten, that will go a long way to kind of protecting while still being exposed to the allergens itself. Some patients are going to be more sensitive, and those unique cases, of course, will work with their allergist to try to figure out sort of the best strategies. I hope that sort of is getting at the question that they're asking about.
Yes, thank you for that. Another question is, how do you prevent IgG-GI mediated allergic reactions?
Yes. So here, what I would, if I'm understanding this question as well, one of the number one side effects that we see with the oral immunotherapy is going to be recurrent stomach ache, sometimes vomiting, and then ultimately, in a small proportion of patients, they may actually ultimately have another disease, what's called eosinophilic esophagitis, and inflammation of the actual esophagus, the feeding tube. And if that is allowed to continue, the concern there is that it can cause inflammation, even swelling, and strictures where it becomes really permanent, difficult to swallow. And so in those cases, at the moment, this is a place where I do think that these alternative immunotherapies could be super duper important. There are some strategies of dosing with oral immunotherapy that can overcome this, but for the patients that can't or don't want to try those therapies, that's where, again, the sublingual or the epicutaneous immunotherapy may be safer versions of immunotherapy with regards to GI, as well as, again, the biologics. So the biologics don't include exposure to the foods themselves. And so those may be safer options for those particular patients where they may either be concerned about or even have risk factors for the GI side effects.
Thank you. Another question for you. What are the main criteria to say that an infant is at high risk for food allergy?
Yeah, that's a wonderful question, trying to understand what makes someone high risk. And we sort of use that terminology twofold. Number one is when I was using it, I'm really thinking, first of all, from the research point of view. And so, in the research point of view, trying to figure out um, who are going to be more likely to become allergic so that we can very clearly demonstrate we can make a difference. Because if you have something where only 1% of people become allergic, to try to show a difference there will take thousands and thousands of kids to show that it's now only 0.5%. So that is, from a research point of view, one of the reasons that we try to identify who's at high risk. But what are those factors that we think of? So within the LEAP study in particular, we did think of atopic dermatitis in particular, ones that are harder to treat. So where you're needing topical steroids or interventions like that does seem to be a risk factor for developing food allergies. Another one is, of course, having another food allergy. And so what we saw was egg allergy does seem to increase the chances that that same kid will be allergic to peanut and perhaps other foods as well. We know that family history definitely matters. And so if you have one family member that is allergic or one parent that's allergic, we estimate 40 to 50% chance that the kid will have some form of allergy. And if both parents are allergic, that number jumps up to maybe 80%. So family history may be one of those. Interestingly, we've not necessarily seen sort of risk within siblings. So one kid being allergic doesn't necessarily make the other sibling dramatically more allergic. But those are some of the risk factors we would think about.
Right. And we'll have one more question before we end. How do you counsel parents or caregivers when they are anxious about introducing peanut, egg, or other allergens at home?
Yeah, I mean it is very, very, very difficult, and not just for patients and for families, but even for the providers, because it wasn't long ago where we were saying don't give it. Again, we were saying wait till the kids are age 3 to give peanut because we want their immune system to be more mature. We want them to be communicative because peanut may be more severe and allergic reactions may happen. And so, number one, I would say, thankfully, we have growing amounts of data that really support that this is safe to do. And even in the kids that react, thankfully, what we're seeing is the youngest kids, the 6, 7, 8, 9-month-old kids, thankfully have much milder symptoms than the older kids may have. And so, number one is there's data to sort of support this. But that's where, again, the allergist also comes into play. And so, if you're concerned, that's what, your allergist can help you. And perhaps that introduction can happen in the form of a challenge in the clinic, somewhere where it's sort of a safe space that this can be done. There are a lot of groups that are out there that can provide sort of support for this as well. So there may be local patient advocacy groups. There's larger groups like Allergy and Asthma Network and FAIR that may have resources that can help with this as well. But I do think that thankfully, number one, the data out there shows us that, yeah, this is safe to give the foods early. We know that it's effective in preventing the allergies. And then between your allergists and your local groups, I do think that there are resources that can help because it can be a scary thing, and that's okay. I mean, it's completely understood that people are going to be nervous about that, and it's right to ask for support.
Well, thank you so much for taking the time to answer some of our audience's questions, and again for an insightful and informative presentation, Dr. Kim. In a few days, Zoom will email you, all the attendees, a link to the recording, as well as supplemental information and a post-webinar evaluation. Your feedback is very important to us, so please take the time to fill that out and give us some feedback or any suggestions you may have. Our final advances webinar for 2025 will be on December 4th. Rhinitis, rhinosinusitis, nasal polyps, and asthma, what to do about that. It'll be presented by Dr. Andrew White. So please register and join if you can for that. Attendees are invited to join and join the discussion on advancing diagnostic techniques, contemporary pharmacological treatments, and surgical interventions, and the role of biologics in managing refractory cases. On behalf of the Allergy and Asthma Network, thank you again for your participation today and registering. We look forward to seeing you in our upcoming webinar next month and next year. Have a wonderful rest of the day. And again, thank you so much, Dr. Kim.
Thank you, Ricky.
Have a good day.